today's session. My name is Dr. Valerie Erulu. I'm a medical officer working in the Pain and Palliative Care Unit. Dr. Nafula is unavailable at the moment, so I'm filling in for her to moderate this session. Today's topic is on informed consent, and I would like to introduce the speaker for today. His name is Dr. Asaf Kinyanjui. He's a palliative care practitioner and a board member at Kenya Hospice and Palliative Care Association, and also a member of Kenya Network of Cancer Organizations. He's an experienced board level leader with a wealth of experience in palliative care, strategic leadership, program management, and research. He holds a master's degree in management and leadership from the Management University of Africa and a bachelor's degree in medicine and surgery from the University of Nairobi. So we can welcome Dr. Asaf to begin his presentation. Welcome, Dr.
Hello, everyone. I hope you can hear me. Thank you, KNH team, for the opportunity. My name is Dr. Asaf Kinyanjui. So this afternoon, and for some of you, probably it's morning, we are going to look at aspect of informed consent. So, Doc, I hope the sound is clear from your end.
The sound is clear.
Okay. So this is a very interesting topic, looking at how we handle issues of consent when we are dealing with our patients and also the people who come to our facilities to seek care. And I'll just start this conversation by just highlighting what informed consent is. We need to appreciate that it's a process, and it's not a one-time sort of contact with the care or with the patient, but it's a process where you as a healthcare provider educates. And we need just to appreciate that when you're having discussions about informed consent, you're educating your patients about the risks, the benefits of your interventions, or the procedures you're going to give. And if this goes even beyond not just the medical care, but even includes research, if you're going to involve your patients and they become research subjects, then you need to take them through that process. So as you educate them, you're giving them information, not instructions. You're giving them information so they can be able to digest that information and be able to come up with a clear decision. So the end goal of having informed consent is you want to reach an agreement where the patient is able to grant you permission to institute treatment or to be able to offer you services. We need to appreciate that informed consent, first, is an ethical requirement, and two, is a legal requirement. Most of the time when as you are administering issues of consent to patient, we just look at it from a legal requirement, and we are quick to just tell the patient, please sign this document so that we can be able to administer this treatment, or please sign this document so that we can take you in for theater for an operation. But first, we need to appreciate that it's an ethical responsibility we have to our patient, that we need to be able to guide them and give them to give them adequate information so that they can be able to make a decision and be able to grant us permission. So it's an ethical requirement first, and then a legal requirement. As we move towards patient-centered care, we need to appreciate that informed consent is part of the patient-centered care. And patient-centered care means that the patient is at the center of making the decision. So they're given information and they make decisions, and they guide practitioners in terms of what the sort of care they need to receive. And also it's also part of the patient safety practices. So if you again want to improve safety standards in your facility, you need to adopt a very good model of informed consent so that at least you're able to ensure that patients also feel that their safety is well factored in. We need also to appreciate that there are two aspects of consent. There is implied consent, and also there is also written consent. So when a patient walks into your consultation room and you want to do a physical exam, most of the time you'll just explain to the patient that they need to lie on the couch, you want to palpate their tummy, or you want to examine their breasts because of the presentation they came to your clinic with. So in that procedure, the patient will comply, and you don't need to have sort of a written document. And that's why we say for non-invasive procedures, we mostly get implied consent. When you want to fix a cannula, that's the same procedure. You tell the patient, I want to fix a cannula because I want to administer medications, and then they're able to do that. But when you're going to have invasive procedures, or you're going to subject your patient to medications with high risk, let's say chemotherapy medications and such, or you want to subject your patient to research, maybe clinical trials and such, then you need a written consent, because then the procedures or the medications you're going to administer have a significant impact on the patient, especially in terms of the risks and also in terms of the side effects. So in those cases, then you need written consent, so that at least you have a document that can be able to that you can be able to take your patient through, and finally you have a document you can always make reference to. So let's just appreciate that we have these two types of consent: implied and written. So what are some of the key components we need to factor in as we discuss with our patients about informed consent? One, we need to make sure that we have some sets of diagnosis, or we have a presumptive diagnosis that we want to maybe dig further, maybe subject the patient to more aggressive investigations, so that we can be able to have a conclusive diagnosis. It's unfortunate that most of the time, or there are some instances where the patient leaves the health facility without really getting information regarding their diagnosis, or why they are receiving treatment Y and not treatment X. The other part of the informed consent is that there is a proposed management plan. So for example, if your patient comes and they have a green foot and you want to maybe go and perform an amputation, so you're discussing with the patient that you have this disease and proposed management is amputation. And then you're moving now to also discussing them why you want to do that amputation, what are the benefits of that. Probably you don't want the gangrene to progress, you don't want them to maybe get severe sepsis, but you also, in the same process, you need it also to discuss with them the risk of that intervention. So for example, if you're going through surgery, probably the risk of they're going to lose their limb. The risk is also that they might be proposed, get risk of associated with anemia, issues of emboli and such, which could arise as a result of the intervention. Even things like infection and bleeding. So those are the things you're going to discuss with your patient. So you need also to offer your patients alternative interventions where it is possible. In most of the time, we rarely do this in our practices. So we tell the patient, we are taking you in for surgery, or we are giving you these chemotherapy medications. We never give them any alternative interventions, probably, which could be available, and the patient can be able to weigh in between the two interventions. Or probably if you're looking at, let's say for a patient, let's say with cancer, are you saying, probably saying we could probably give you chemotherapy, but there's also a possibility that if you are to subject you to, let's say, radiotherapy, you still have some significant element of control of the disease and probably even a cure. So you also need to discuss with the patient's costs. This is another area where we fail mostly as a practitioners, healthcare practitioners. When the patient comes into your facility, you tell them you want to subject them to, let's say, treatment. And when they ask you, Daktari, what is the cost? You have no idea. And you end up sending them to a different department. If you work in these big facilities, most of the time the patient gets lost in the corridors, and they rarely know how much they rarely even get to the department where they can get accurate figures. So it's very important for us, even just look at, have a rough idea how much some of these interventions cost, so that at least the patient is also able to look at, if I take management plan A, this is a cost implication. If I take management plan B, this is a cost implication. Discuss with them also the possible outcome if they decide not to take your interventions, or what we mostly prefer is refuse treatment, so that they also know that that is also a possibility. They have a right to decide not to receive what the treatment you're proposing, but also you're also educating them that if they take that route, these are the possible outcomes. Again, if you use a patient with gangrene, so you're telling them probably the infections will get worse. you're telling them probably they are going, if they were to lose, maybe you are to do below knee amputation, then you probably by the time they're making decisions will be above knee amputation and such. So they're able to have a clear picture of how the urgency of also your interventions you want to undertake. You also need to ensure that the details of a healthcare provider and the patients are included. And finally, that you have the patients, even and the healthcare provider appending their signatures into the document. What you need to make sure is that you need to make sure that all this information is very accurate, and therefore you need to have very good way of managing and identifying your patients. Where resources allow, actually this process actually should be administered by 2 healthcare practitioners. So just to ensure that information is relayed as it's supposed to. And also there's also element of making sure that both of you are able to confirm the patient details so that you don't tell a patient who doesn't require chemotherapy and you're discussing with them about issues of chemotherapy, because sometimes we have patients sharing almost common names, and we could end up with confusing and giving the wrong information. So it's very important to ensure that we properly identify our patients even as we take them through the process of informed consent. One of the things I would hope out of this talk is that we will avoid what we are seeing in the diagram, the first diagram, where we usually have a patient who comes to a facility. We, even in non-emergency situations, we just present the consent form to them and we tell them, please sign here. And you can see from the diagram, it's almost like 6-7 paragraphs. The patient there even has a chance to read even the first paragraph, and you're in a hurry to just make sure that you get the signature and off. That's not informed consent. That's something else which we should actually abandon. I've seen in some instances where the healthcare practitioner actually, when they're wheeling the patient to theater, the other one is also alongside this patient and saying, hatuwezi ingia theater kama hujasaini hii form. And that the time the patient is being subjected to, they are seeing the contract or the informed consent for the first time. So it is ideally, that's not a good practice, because then again, what you're not getting is, it's just a consent, but it's a consent where the patient doesn't appreciate what they are signing against. So if you look at the other diagram where you're looking at issues of the informed consent, you have the patient's knows his diagnosis of the potential diagnosis. They know the risk and the benefits of the treatment they are undergoing or the procedure. They also appreciate the benefit of alternative treatment. And they're able to make informed decisions because you have tabled down all the necessary information, including cost. So colleagues, one of the things I would really urge you is that as you continue providing care to your patients, please create time and don't subject your patient to signing consent on the theater door, just to ensure that you have a signature. It shouldn't be the case. And as I mentioned that informed consent is an ethical requirement, and there are some few things we need to appreciate as we take our patient through informed consent process. We need to appreciate that the patients have autonomy. So they have a right to make health-informed decisions, including refusing or withdrawing from treatment. And we shouldn't, if the patient decides to refuse or to withdraw treatment, we should also be able to be kind enough and take them through and educate them with the consequences of the action. Again, most of the time we get very emotional when the patient says, I don't want to undergo this treatment. We just pull another form saying, sign here to say you have refused treatment. Ideally, that shouldn't be the case. We need to sit down with your patient and appreciate why they're having that challenge. We need also to appreciate the other ethical principle that would guide us through this process is the principle of beneficence, where it means that you do good to your patient, and every intervention you're going to do to your patient is meant for the good of their healthcare. We need to be accountable, again, as healthcare providers, and be relied upon. I've seen it again where we have big institutions and you have patients who require, or there's delegation of getting consent from the patient. It's delegated maybe from the consultant to the medical officer or to the nurse or to the clinic officer or whoever else. that person doesn't usually have do due diligence and provide the right information. They just rush to get the signature from the patient. So that's not accountability. We need to ensure that we are able to provide, we are accountable and we are able to give accurate information to our patients. Sometimes we even in terms of accountability also touches in terms of sometimes you have a lot of temptation to rush the patient, let's say for a procedure, because of what you're going to gain monetarily. So again, that's also something goes against the principle of being accountable. We need to tell the truth to our patient and they also have effective communication. Effective communication means you're also talking to the language that the patient is able to understand. As medics, we are prone to using a lot of medical terminologies which are not very clear to our patients. So we need to make sure that we use languages which they and use the terminologies which are familiar with our patients. And you need always to tell the patient the truth. And finally, we need to ensure that even you as administer this consent, that you're not doing harm to our patient, and because also we'll be violating the ethical principle of non-maleficence. We also need to appreciate that there's legal requirements for consent, and we need to look at our constitution. And I know we have also some people who are not from Kenya, but from other parts of the world. But and I believe even if you look at your country constitution, has some elements of about right to health and such. So for Kenya, we need to appreciate that Article 43 of the constitution provides that every person has a right to the highest attainable standard of health. So if you're not going to offer highest standard of health, then it means that you must make sure that you are giving your patient the right information for them to make the right decision. And also, you also need to appreciate that every healthcare provider shall inform a user whether the user of the information is a minor or in the situations where the user is a minor or incapacitated, then you're looking at informing the guardian. And you're informing them about the diagnosis, the benefits of the treatment, the risks, the costs, the consequences, and also their rights. So again, this is also a requirement by the law that we should inform our patients about their diagnosis, about the treatment, the cost, the risk, and the consequences, and also about their rights to health. We not also appreciate that the Constitution also spells that no specified health service may be provided to a patient without the patient's informed consent. So we shouldn't provide care to our patients unless the element of informed consent. But we are going to look at, as we continue this conversation, where we have some special circumstances where we look at where we might not be able to get informed consent and we need to administer healthcare interventions. So a healthcare provider, again, the Constitution says requires that the healthcare provider must take all reasonable steps to obtain the user's informed consent. So we need to ensure that we allocate adequate time. We need to ensure that we have effectively communicated to our patient, because it's again a requirement by the law that we are taking all reasonable steps to ensure that we obtain informed consent from our patients and our clients. So how does this process start of administering informed consent? First is you need to identify whether your patient or the person they have delegated the responsibility of giving consent. You need to ensure that they are adults, and in Kenya we look at 18 years and above, and you don't also need to identify that these individuals are of sound mind. So that's one of the requirements even you need to start with. Then number two, you need also to look at the issues of reasonable patient standards. And this means what you're looking at your patient and look at as judging which information do I need to provide for my patient for them to guide regarding or for that information to guide them to make informed decision. Not for them to give you consent, for them to make informed decisions. So you're looking at patient, this is an elderly man from the village. There's some terminologies, there's some informations, if you give to them, they might not really help them in making decisions. So you have to look at your patient from a holistic perspective and from their background, and be able to package information that is more appropriate to them. The other bit we need to ensure, and this is where we fail most of the time as healthcare practitioners, is that we don't allocate adequate time to provide information to our patients. So again, if you want to have informed consent, you need to create adequate time to provide information to our patients. This will not happen if you are doing it as you rush your patient to theater, or as you're mixing your chemos, or you're administering your chemotherapy, or any other aggressive intervention. And when you're almost fixing the cannula, that time you're telling the patient, please allow me to continue with this treatment, or allow me to continue with this procedure. So you need to, prior to even the intervention, you create time and provide information to the patient. Use a language that is easy for patient to understand. If in some instances where the patient is not able to use the national languages, you might need to even include having an interpreter who will be able to deliver your message to your patient in a way that they're able to images. This helps also the patient to visualize what you are discussing, and so and helps them to make a more informed decision. Ensure, again, you are also in a comfortable environment. Sometimes also we usually sometimes get informed consent as we are doing our major ward rounds. You have a group of about 20, 30 individuals surrounding a patient. The other patients in the next door, in the next bed, receiving the physio and other interventions. It's in a noisy environment. So the patient is not even comfortable. They're not even listening to you and such. So you need to ensure that you're in a comfortable environment when you're administering consent. And the other bit is also you need to provide some reference materials that the patient can continue looking at as they make their decisions. So sometimes I know there are some, especially the private facilities, are able even to provide a copy of the consent, and it's encouraged that you give the patient that document. And finally, we also need to ensure ourselves as healthcare providers, we have the capacity to provide the required information, we are able to respond to the patient's concerns, and we are able to respond to those concerns adequately. I've seen instances where, let's say, a surgeon delegates the aspect of getting the informed consent to a junior, let's say, medical officer, or sometimes even an intern. And the surgery is quite complex. So when the patient asks this junior medical officer or intern tough questions because they need to understand maybe the complexity of the procedure, they nearly get the correct information. Most of the time they are told when the consultant comes, I'll ask them and then I'll get back to you. So one of the things we need to ensure that if in most of the circumstances, the person who is going to undertake the procedure should actually be able to administer the informed consent. That should be the best practice. Where sometimes because you have limited personnel, then we need to ensure that as we delegate the responsibility to our junior officers, we also empower them that they're able to provide adequate information and accurate information to our patients so that the patients are able to make informed decisions. There are some instances where there have been a conflict. The surgeon says, I want to go and do above knee. Well, the intern says we are going to do below knee. So when the patient wakes up after theater, he finds it's above knee and says, this is not what I was told. Therefore, it's very important that whoever you delegate the responsibility, you also empower them adequately to provide the required information. We need also to appreciate that this is a voluntary process. We need to do it without coercion or without putting a lot of pressure to our patients. Again, this is an area where we have a lot of challenges in our facility. So in some instances, patients have been threatened. And I've seen even pregnant mothers where they have obstructed labor. They want to go in for cesarean section. The healthcare provider says, you must sign here. And the words they use is quite threatening, that the patient feels like you're almost holding a gun on their neck or their head, and you're waiting for them just to put that consent. We need also to ensure that our consents are properly documented, they are signed, and also they also need to ensure that once you get that consent and the document is complete, it's well filed. We have had instances where also the patients, there are complications and people are looking at patient's file and you find the consent is missing. That shouldn't be the case. So you need also to ensure that we have proper way of keeping patients' details and documents so that at least when you need to make reference to, those documents are available. As I mentioned, there are special considerations we need to factor in as we do this. One, we have children who are minors, and these are individuals who are 18 years and below. So in most of the instances, we find that their guardians are the ones who give consent. But we also need to ensure that children and minors who are below 8 years, we also take time and inform them about the treatment, about the intervention, in the goal of getting informed permission. Informed permission means that probably you're not going to have a document that you're going to sign, but this individual appreciates that they have a right and they have a role to play in their healthcare and in making decisions. So again, this is an area where we don't do very well especially in pediatrics. We just come and talk to the parents, they sign the document, we tell the child from today up to tomorrow, do not feed on anything, and we walk away. Please, colleagues, let's not do that. Let's engage the children, let them appreciate why they're in hospital, let's appreciate them appreciate why you're doing the interventions, so that they can also be able to feel they're part of the treatment and they're not just there to receive instructions from the seniors or from their parents. Again, use the language that is more age appropriate. If it's a child who is 10 years, it will be very different language to a child who is 15 years or 17 years. So please, again, also need to consider that age differences in this group requires us to use different modalities. Sometimes we might need even to use cartoons, or sometimes we might need to use drawings so that we're able to drive that message very effectively to children. Just to give an example, recently we had a child, a young girl with osteogenic sarcoma, required amputation. So when the healthcare providers discussed with the parents, they agreed, the parents signed, and the surgeon or the healthcare providers, actually, they were set to take the patient to theater. Unfortunately, on that day for operation, the girl said, no, I don't want to be operated on. I don't want amputation. I want to be a model in future. Once you do this procedure, how am I going to continue being a model? When you realize why she's doing all these issues is because she hasn't really appreciated the magnitude of the illness and why she needs to undergo that procedure. So it's very important for us just to ensure that we get informed permission from the minor so that they're able to feel they are part of the treatment. We have some situations in emergency cases, and sometimes as a healthcare provider, you might weigh that you don't have adequate time to obtain consent. If the patient comes, they have been involved in a road traffic accident, they have severe bleeding, you have a role to start providing emergency interventions to this individual as you wait to maybe discuss issues of consent later. And this is why we say the doctrine of presumed consent applies. And the law is something recognized in the law that in emergency situations, you are allowed to give treatment for the best interest of the patient, and you discuss the issues of consent and consequences of the treatment later. You also have patients who are incapacitated mentally. Maybe the patients who are severely elderly, there are patients with dementia, or sometimes the patients with severe mental illnesses. For you to say that this patient is incapacitated and not able to make that decision, you need to make a formal review of this patient, and sometimes you might need to involve other experts, sometimes even a psychiatrist, so that you have a well-documented information that, yes, they have been reviewed, and for sure this patient is incapacitated. Where they're incapacitated, then you need to look at somebody else who will be able to give that consent on their behalf. And that's why we talk about issues of surrogate decision-making. You find in some situations, patients